Hi, my name is Jeanette Domask, and I am an OMIC risk manager. And the presentation today is focusing on a systems approach and culture of safety to enhance patient safety and reduce liability risks. So we're often asked to present the most frequent allegations in lawsuits and provide recommendations to help practices avoid these errors. So really the biggest impact to mitigate risk in your practice is to focus on a systems approach and create a culture of safety. So we'll discuss in detail what that means and how to achieve this culture. And this approach, it might involve looking at issues from a different perspective, but this isn't a difficult or novel concept to adapt to your practice. So in litigation, it focuses on who's to blame and who's at fault, but it never actually fixes the underlying problem that lead to the error. Physicians do not work in vacuums. They work in complex healthcare systems, and human errors are inevitable. A systems approach can help with the design and the integration of people, processes, policies, and organizations to eliminate or reduce the opportunity for human errors. So shifting the focus from an individual blame to a systems approach by empowering staff to identify and address systemic vulnerabilities helps to proactively reduce or eliminate malpractice risks. So we'll talk about medical malpractice, some OMIC claim statistics, highest settlements and common allegations, and then most of the presentation will be on the systems approach, which is to improve systems and processes for patient safety and risk mitigation, and then also incorporate a culture of safety. And then we'll have case examples as well. So first, for some OMIC claim statistics, as of January 1st, we have 431 open claims and suits, and the majority of our claims do come from cataract and retina, and historically that's also the case. Average indemnity payment. This slide shows since 2011, average indemnity has been gradually increasing, and last year it did increase significantly. The average indemnity was almost $400,000 per claim. This slide shows the open claims by state. And majority of our cases do come from California, New York, Pennsylvania, and Florida. And historically, that's where most of the cases come from. We do have a large volume of insureds in those states. They also are highly litigious states as well. This slide shows the largest settlements in OMIC's history, the top 10. And as you can see, you'll see failure to diagnose or delay in diagnosis as the allegation. And when you look at that, you think, oh, one person was to blame. But most cases, it isn't just one person that's to blame for a case. Oftentimes, there's multiple events, multiple errors that occurred, lots of system process issues that led to the patient safety event. So allegations that are made in litigation, they include surgical errors, that can be wrong site, wrong patient, wrong procedure, failure to diagnose, that can be due to delay in referral or testing, incomplete patient history, clinical judgment, a delay in diagnosis, that can be due to poor communication or non-compliance on the patient's part, system and process errors, that can be due to lack of standardization and policies and procedures. And I can argue most of these are actually systems and process errors or can be considered system process errors. Informed consent is a frequent allegation in litigation. It's the allegation is usually it was lacking, the informed consent was lacking, or it was inadequate. There's also medication errors, wrong dose, wrong route, wrong medication. So a system approach, the goal is to improve patient safety and reduce adverse events and mitigate risk. So that's a shift from a systemic look at events versus focus on human errors and blame. I'll go over the Vanderbilt case to highlight a systems approach. Then I'll discuss tools that you can use proactively. You can use a risk assessment, and after an event, you can use a root cause analysis as a tool to take a deeper dive into an event and come up with an action plan to ensure that doesn't happen again, and then following up with an action plan to prevent future adverse events. So a systems approach. So human error is inevitable, and striving for perfection or punishing physicians or staff will not improve safety, and it's not realistic. Most errors that lead to an adverse event do not occur due to one action, but rather due to systems and process failures that lead physicians and staff to make mistakes. And we'll highlight this with the Swiss cheese model. So a systems approach shifts the culture of blame to one of solving system and process issues that are contributing factors and root causes of the errors that lead to the adverse event. And the systems approach incorporates a culture of safety, which is a blame-free environment for individual reporting of errors or near misses without the fear of punishment. Safety and the reporting of unsafe conditions is a responsibility of everyone, and there is an organizational commitment to address safety concerns. So the case study is the Vanderbilt case. This involved the nurse Redonda Vaught. This was a wrong medication event. And this case highlights why the systems approach is really important to proactively mitigate risks before they occur by attempting to eliminate the risk of human error. So in this case, the nurse administered vecuronium instead of Versed. Vecuronium is a paralytic, and it caused the patient's death. The nurse ended up losing her license. She was convicted of criminally negligent homicide and was sentenced to probation. And in this case, the nurse did admit to 10 separate errors that allowed the wrong medication to be administered. But when you look into what happened in this case, there were multiple system and process issues that if they were addressed proactively, this would not have happened. In this case, Vanderbilt was encouraging the use of workarounds to expedite tasks. They were using 2-character ID in the medication cabinet instead of 5, so improving technology to change the ID. So she typed in VE and got the wrong medication. If you had 5 letters, you wouldn't have been able to get the vecuronium. There was no scan available in the radiology room to confirm the right medication, the right patient, and there were technology issues with the EMR and the medicine cabinet communicating. So designing a system to eliminate the chance for a human error would be more helpful than labels, warnings, vigilance, policies, discipline, and training. So human errors are inevitable, but the system approach will design systems that are safe and efficient and usable for staff. Because you get distracted. This actually happened on the 26th of December. I used to handle litigation, and you would often hear about cases that occurred during the holidays when you either had a skeleton crew or you had staff that was working in areas they didn't normally work in. And in this case, she was in the radiology department. That was not an area that she normally worked in. There were lots of mitigating factors to why this error occurred. Yes, she did make a significant error, but there were opportunities for system improvements to avoid some of these human errors. So again, adverse event factors can include system and organizational factors. That can include workflow, resource constraints, inadequate staffing. There's technology issues such as problems with electronic medical records, medication administration systems. There's human factors and behavior, communication breakdowns, ineffective teamwork, fatigue, burnout. There's patient-related factors. Health literacy is a big issue. Lack of engagement and non-compliance with treatment is a potential factor. And then there's external factors related to the environment, economic, financial pressures, etc. So the Swiss cheese model, this is an analogy that helps to demonstrate contributing factors that lead to adverse events. So the slices of cheese represent a defensive patient safety strategy in place. For example, some strategies may be focused on improving communication, changing the physical work environment, or scheduling staff. As systems can be imperfect, the holes in the cheese represent situations where the defenses in place have not provided the intended preventative control. So by layering multiple defenses, there's a greater likelihood that the next layer of defense will prevent a patient safety event from occurring when one hole appears. However, when multiple holes in the Swiss cheese line up and none of the intended defenses work, the patient safety event may occur. So the system approach investigation of patient safety events focuses on identifying these holes that may have contributed to the event occurring, recognizing that in isolation, these contributory factors may not cause harm, but once contributory factors are identified, system solutions are implemented to continue plugging these holes within the Swiss cheese. So the cycle where issues are identified, analyzed, solved, and monitored is a core aspect of continuous quality improvement and an integral component of high quality healthcare. So one of the tools that can be used to focus on a systems approach is a risk assessment. And this is done proactively, so before an event occurs. So with a risk assessment, you can have a tool or a survey to identify strengths and weaknesses in the practice. You can do a systematic review of policies and procedures, focus on having systems and processes in place to reduce or eliminate human error, and then organizations can make improvements based on weaknesses or gaps in the system. And this is a service that OMIC does offer to do a proactive risk assessment. It can be a broad one covering all sorts of different topics, from how do you handle the informed consent discussion to how do you deal with a difficult patient. And this is something that we can do, or you could do a focused one on the surgical safety checklist, which includes the timeout. So there's different ways to do risk assessments. Another tool that can be used is a root cause analysis, and this is often done after an adverse event. And these are done in ASCs and in hospitals. They are required for accreditation to do an analysis after an adverse event occurs in those facilities. So the first step is to form a team to investigate the event. So they gather information about what happened. Then you evaluate the systemic contributing factors that led to the event, determine the root causes of the errors, and then develop an intervention plan to prevent future events. So that's the key to doing a root cause analysis. You want to make sure it doesn't happen again. And then you want to communicate that intervention plan and reassess for compliance and effectiveness. So part of the root cause analysis, you can use a fishbone diagram. And the fishbone diagram helps to facilitate a discussion to talk about contributing factors and which of those contributing factors were the root causes and which of those root causes you should develop an action plan for. So you look at the categories people, environment, policies of procedure, and equipment. And you can see under people, they were short-staffed. You know, there was a lack of culture of safety. Staff didn't feel comfortable speaking up. The surgical safety checklist wasn't standardized. You know, is there simulation training for the checklist? There were distractions. There was high volume in the environment. There was a new laser being used. So you discuss all these contributing factors and then come up with what were the root causes of why this happened. So the action plan that was developed from this event was to standardize the checklist. You know, do simulation training with staff. Make sure everyone knows what their role is during the surgical safety checklist. That includes the pre-surgical verification, the timeout, and the post. Have an incident reporting system. You know, do you have a system where staff can report near misses and actual patient safety events? You can analyze near misses to proactively come up with ways to prevent those from occurring again. You can empower staff to speak up with the culture of safety and then integrate the EMR. So for risk reduction strategies, usually multiple strategies are needed to build a safe system. High level leverage strategies are most effective because they can eliminate the risk of errors and associated harm by designing out hazards. However, they often require complex implementation plans and resources. Medium level strategies, which are easier to implement, help to reduce the likelihood of errors or minimize harm. However, they may need periodic updating and reinforcement, and alone will not protect the patient 100% of the time. Low leverage strategies, which aim to improve human performance, are easy and quick to implement. However, they are the least effective strategy for error prevention, although they are frequently relied upon. So it's better to focus on simplifying or standardizing processes, checklists, technology enhancements, simulation training, enhanced documentation versus education, retraining, that sort of thing. So this is an example. An action plan, you want to simplify workflows, standardize the processes, technology enhancements like the 5ID, character ID in the medication system, forcing functions, redundancy, that's always good. Someone else is checking, there's redundancy. So if there is an error, it's caught by one of the other backup systems. And then simulation training is more effective than just rote training. And then the elements of a culture of safety. Culture of safety is making sure your staff feels comfortable speaking up. You know, if they see something, say something. They you can't have your eyes on everything, so it's really important that you empower your staff to be on the lookout for patient safety issues. Have that open communication, make sure that they report events, have good communication for handoffs and transitions, have a non-punitive response. You know, if a staff member does make a mistake, you want them to come to you and tell you the mistake was made. Have organizational learning from near misses and events. You know, teamwork across the units. These are all elements of a culture of safety. You know, human errors also, you know, behaviors should also be addressed. So there's different types of human errors and different responses for those. You know, there's human error where it's just an inadvertent slip or a lapse, and this happens. People get distracted, they're tired, and they make a mistake. So the response would be to, you know, support the person who made the error, but investigate how the system can be altered to prevent the error from happening again. So if it's that easy to make that error, is there a way to improve that, fill in that gap so that if there is another human error, that the event doesn't cause a patient safety event. Sometimes there's at-risk behavior where the staff member consciously chooses an action without realizing the level of risk. In that case, the staff member should be counseled about why the behavior is risky and investigate the reasons they chose the behavior and enact system improvements. And then finally, there's reckless behavior. And if there is reckless behavior, this does warrant disciplinary action. So culture of safety doesn't mean that you don't address issues with staff behavior. Just means that you take a look at the behavior. This also highlights there should be some kind of peer review process. That's physicians reviewing other physicians. It should be non-punitive as well. Peer reviews shouldn't just be done when there's an issue. It should be a continuous, ongoing, and it is typically a requirement for accreditation, different accrediting agencies. So having a peer review process is really important. So the first case I'm going to discuss is a wrongful injection in the clinic. And in this case, this was a patient that was 61-year-old receiving monthly Avastin for wet AMD. Patient missed a July visit due to an illness and returned in August. The vision had decreased, and the physician's impression was the vision loss was attributed to the missed July appointment. The physician administered an injection of aflibercept, and there was no mention of a high pressure in the physician note. And this table shows the pressure readings for the last 6 months. Of note, there was no documentation in the physician note of these elevated pressures in any of the notes. Patient returned in September. The visual acuity was light perception on the right. Pressure was 45. The cup to disc ratio had increased. Patient was diagnosed with glaucoma. A paracentesis was done. Patient was started on medications and referred to a glaucoma specialist in the practice. The physician realized the mistake and apologized to the patient for missing the elevated pressures. 5 days later, the physician went to the glaucoma evaluation, was light perception, and it had a pressure of 10, diagnosed with angle closure glaucoma on the right of severe stage. The plan was a laser iridotomy, and the patient never returned to the practice. The patient ended up filing a lawsuit against the physician and the practice. The allegation was failure to evaluate and treat the elevated pressure, negligent injection of the aflibercept. The damages were chronic angle closure glaucoma. The patient lost vision and claimed pain and suffering, past and future wage loss. So at the physician's deposition, the physician recalls the visual acuity and the pressure recorded in the EMR, but they're not always available on the summary page. And the process in their practice was the technician was supposed to alert the physician of any pressures greater than 30. So the physician said he never knowingly performed an injection on a patient with a pressure over 30, and he believed the tech didn't communicate that elevated pressure, but he ultimately took responsibility for not confirming the pressure before the injection and admitted to negligence. The reviews revealed that failing to timely recognize the high pressures over time caused optic nerve damage and loss of vision, and the deviation from the standard of care for failing to recognize the elevated IOPs or pressures at 4 different visits, that was below the standard of care, and failure to evaluate and treat the elevated pressures was most likely the cause of the vision loss. The case settled for $360,000. So in this case, if you look at it from a root cause analysis, I had done a risk assessment with this practice, and the same tech was at each visit. There was high tech turnover, so just lack of following policies and procedures, lack of training, lack of a culture of safety. There was no surgical safety checklist using in the clinic, and even with injections, we do recommend use surgical safety checklists in your office clinics, whether it's office-based surgery or procedures in the office, because we do get frequent calls about wrong patient, wrong site, wrong procedure in the clinics, and using those you can shorten them. They don't have to be as lengthy as what you use in the ASCs, but they are recommended. There was a reliance on non-licensed staff to remember to report the pressures to the physician, and also the EMR didn't flag the out-of-range results. So as an action plan, the decision was to do simulation training with staff on the surgical safety checklist and adopt that in the clinic as they have in the ASC, also to add the pressures to the checklist, and then to request the EMR vendor flag out-of-range results. So these were simple system processes that could be implemented to fill in these holes in the Swiss cheese. So this is an example of a surgical safety checklist. This can be pared down in the office setting, but this can be adapted to your own practice and added to what's necessary, needed in the clinical setting. The second case we have is a wrong lens event. And in this case, the patient's right eye cataract surgery is scheduled for the third cataract procedure of the day at the ASC. And on the morning of the surgery, the second procedure was canceled, and the third procedure was moved to the second time slot. So in this case, the nurse used the second patient's information for the IOL for the timeout. So the record indicates the timeout was done, but it was done using the wrong patient's lens. The nurse discovered this error in the PACU, disclosed the error to the surgeon. The surgeon compared the intended lens with the implanted lens and decided to proceed with an immediate lens exchange. When the patient was fully alert, the surgeon disclosed the error and let the patient family know he did the exchange. So on post-op day 1, the visual acuity was 2400 without correction on the right. Patient had moderate corneal edema. The plan was returned in 2 days and medication was prescribed. On post-op day 3, the visual acuity was counting fingers. Patient expressed he was angry about the event, continued to have corneal edema, and that the vision should improve with time. 1 month post-op, patient's visual acuity was 20/80, the pressure was 16, the OCT was normal, the retina was normal, but the corneal edema persisted. Medications were prescribed and the patient never returned. So the patient ended up filing a lawsuit against the surgeon and the ASC due to the incorrect lens that was placed, claimed decreased vision, continuing eye pain, light sensitivity, and headaches, and pain and suffering. The reviews revealed that obviously the wrong lens being placed was below the standard of care, but the experts also felt that the second procedure caused the corneal edema, but the patient did ultimately recover vision, but it may be difficult to prove that the second procedure is the direct cause of the ongoing pain, headaches, and photophobia. It's hard to say that that didn't cause the corneal edema. The OMIC reviewer also felt that it was below the standard of care to follow a surgical safety checklist, and they commented that not getting consent with the lens exchange, which is debatable. It's not set in stone where you would necessarily wake the patient up and get the consent. Another option would be to go into the waiting room or call the surrogate decision maker and let them know what happened and get consent from them to do the exchange. But this case settled for $750,000 and was split equally between the physician and the ASC. So in this case, issues that led to the error included the schedule had changed with the cancellation. The patient was upset. There was a lack of culture of safety. The surgical safety checklist wasn't standardized. There was no comparison of the patient name with the consent. If you had compared that or with the plan, then it would have been caught that they had the wrong lens for the wrong patient. There's no clear policy on what you do with a lens exchange. There were different EMRs in the ASC and the clinic. So as an action plan, there should be a process for handling schedule changes. There should be simulation training for the surgical safety checklist. There should be a reconciliation of documentation, so comparing the documentation of what the plan is with what the patient, and then a policy on reconsenting. So the purpose of informed consent, that's for patient autonomy to make informed decision, ensures the patient's fully aware of the risks, the benefits, the alternatives, it sets expectations, it strengthens the physician-patient relationship, and it's used to defend the physician from negligence allegations in the case of adverse events. So the process, the informed consent is a process, includes both the discussion and the form. So the discussion should include an assessment of the patient's capacity to decide. If the patient doesn't have capacity, then you need to discuss the consent with a surrogate decision maker. You disclose the required information, risk, benefits, alternatives, and then assess the patient's comprehension. Using the teach-back method is an example. Ask the patient in your own words, tell me what the plan is and what our goals of the procedure are. And then The signature on the form is the agreement that the patient wants to proceed with the procedure. This is the physician's non-delegable duty. They can't ask someone else to have the informed consent discussion with the patient. They can ask other staff to help with the education, but that discussion is the physician's duty. And the informed consent is not only a signature on a document, it's also the discussion. The discussion should be well documented. Avoid using templates with things that you didn't discuss. You want to make sure whatever is in the record is something that was actually discussed with the patient. And then providing a patient with a copy of the consent is also helpful because it has all the details and they can take that and review it at a later time. So when you obtain a form consent, it's important to use plain language, avoid medical jargon, educate with visual aids, diagrams, videos. If you do use those, make sure you document those were used. Allow time for the patient to ask questions. Set realistic expectations. Don't make any guarantees. Encourage they include family and friends, especially if a caregiver is needed after the procedure. Assess the patient's understanding with the teach back, tell me in your own words the plan and goals of the treatment, and then document that discussion in the medical record. That's really important to have that documentation of what you discussed with the patient. It should be accurate of details of what you relayed to the patient in addition to them signing the form. So often in our suits, informed consent is an allegation. It's not usually the main allegation, but it is an allegation of lacking or inadequate informed consent. And relying on the hospital or surgery center's consent form is not recommended. These generic documents rarely address ophthalmologic specific and procedure specific risks. I know in the hospital, they do use those generic consents, and sometimes even the documentation is very sparse. So when you do get a patient complain about a complication, if you don't have the documentation to support that was discussed, it's hard to defend if it ever turns into litigation or even before litigation. So the informed consent discussion and the documentation is critical to the success of a defense of a claim. So the risk recommendations: develop a policy and protocol for the informed consent process to ensure consistency, to use procedure-specific forms and provide a copy for the patient. Informed consent is the physician's non-delegable duty. It's not only a signature on the consent form. Document the discussion details along with the procedure-specific consent to strengthen the defense. Another topic that comes up that's important to have a process in place is an adverse event disclosure. So when an adverse event occurs, you want to focus on the patient condition and the treatment needs to mitigate the effects. Make sure that you preserve any evidence, whether it's packaging, medication, devices, anything, preserve that. Report to risk management, whether you're in a hospital, ASC, or your carrier. Before you talk to the patient, if you have the time, you want to debrief with staff to gather the facts, because oftentimes you might think you know what happened, but there might be some more details that you need to gather before you talk to the patient, and then develop a plan to disclose to the patient. So have the disclosure with the patient and or family. Advise them of the effects of the event, and then move them forward to the next steps in their treatment. And then document that you had this discussion with the patient. Now with this in adverse event disclosure, it's really important to relay only the facts. Don't offer a hypothesis of what you think might happen. Don't place blame on someone else. Just stick with the facts. Use empathy. Say, I'm really sorry that this happened. You want to give them your contact information. You don't necessarily have to pass out your cell phone. Depends on the event, but just a way to reach you. And then let them know you will share any additional information as it becomes available. So the disclosure sometimes is an ongoing event where you're relaying additional information. You know, patients do want to know that you're taking it seriously and that making sure that it doesn't happen again. And so you want to actually complete a formal investigation. You plan in that investigation to prevent a recurrence, and then you can report the event to the facility or your carrier, and then provide staff support and training. But it's really important to do a type of a root cause analysis when you do have an event so that it doesn't happen again. And you can tell the patient that you are looking into it, that you're going to investigate it, and then come up with an action plan to make sure it doesn't happen. Oftentimes those discussions are quality protected, so you don't want to discuss the details of those discussions, because if you do, that could be potentially discoverable. So it's really important, just you can tell them that you're looking into it, that you're going to make improvements, but don't discuss the inner working, the details of your quality protected discussions, or they're no longer quality protected. So part of the with the empathy of saying I'm sorry, majority of states have what's called I'm sorry legislation, and that means that you can say you're sorry to the patient without fear of them using that against you in litigation. That's not admissible evidence to say, look, the physician said that he or she was sorry. That means they're at fault. That cannot be used against you. Legislators across the country have passed these laws because it's very important. Patients really want to hear someone say that they're sorry about the event. So these laws have been passed, so they cannot use this against you. Another area that really is helpful to have proactive policies and procedures in place before an event occurs or before an issue occurs involves like patient challenges. So there are patient challenges with hearing or vision impaired, communication challenges, elderly cognition issues. There's health literacy challenges, limited English proficiency, patients with unrealistic expectations, difficult family members, lack of social support with patients, and then financial stressors. So these are various challenges that you encounter in your practices. And these challenges can create liability risks. They can create patient noncompliance. They can create workplace violence events, regulatory failure if you don't obtain an interpreter. They can also create unmet expectations, which lead to dissatisfaction with treatment, complaints, claims, and lawsuits. So it's really important to take a proactive approach, anticipate issues and how to prevent problems in your practice, provide a framework for response and action. So often one example is a patient who is verbally abusive. You want to make sure staff comes to you and reports this, because oftentimes if staff's not told to come and report these, it happens over and over again until the staff member says, I can't work with this patient again, and then you're in a tight bind. So you want to make sure before it escalates, just have staff report to you if there's verbal or physical abuse, and that they report it to you and then you address it right away. Whether it's the physician or the practice administrator, that's up to your practice how you want to handle it, but you should have something in place so that you know what to do and how to work through that. Oftentimes you talk to the patient instead of just automatically terminating them, but talk to them, let them know that in your practice you expect mutual respect, and that if it happens again, that you're going to have to terminate them from the practice. So it's really important to just have something in place, make sure staff reports to you, and then you immediately respond to the event so that it doesn't escalate and continue to happen. You also want staff to know that you have their back, that's not part of their job to be verbally or physically abused in the workplace. So other topics that really should have focused policies and procedures and have, systems, processes in place, include non-compliance, disclosure of adverse events, informed consent, workplace violence, patient complaints, culture of safety, qualified medical interpreters, incident reports, and terminating care. So all of these can help if you have a policy and procedure in place that can help you navigate these issues when they come up and create that culture of safety for your patients and for your staff. And finally, in conclusion, focusing on a systems approach and incorporating a culture of safety that recognizes all staff are part of a team which have responsibility and the ability to recognize, recommend, and implement system and process improvements, provide safe patient care, and prevent adverse events. And these were references that we have involving, AHRQ has some good references, the World Health Organization, CDC, the Minnesota Department of Health has a nice root cause analysis toolkit. And then on omic.com, we have lots of resources to assist you in implementing these policies and procedures. And finally, this is how you can reach us, and we appreciate you listening. Thank you for your time.